Good evening, aspirants. Today's class is on respiratory failure and it will be taken by Dr. Asif Iqbal. So, sir, I hand over the class to you.
So 40-year-old previously healthy 90 kg man, ideal body weight is 80 kg, walk into the emergency department complaining of 5 days of myalgia, fever, rhinorrhea and dry cough. Over the last day, he has become short of breath walking across the room. In the emergency department, he is febrile, hypotensive, require vasopressure with respiratory rate of 30 and saturation 88 on non-breathing face masks. He received 30 ml per kg crystalloid and developed worsening walk of breathing requiring endotracheal intubation 2 hours after arrival in the emergency department. Endotracheal tube placement is confirmed by end-tidal carbon dioxide, bilateral breath sound, and his SpO2 nadir is 75%, but despite 5 minutes of bagging, his SpO2 remain in mid-80s. The chest X-ray shown below. So, what is your diagnosis in this case? Somebody please volunteer.
Sir, ARDS.
It look like a ARDS. Yes. So his chest X-ray, bilateral infiltration is there. High patient after giving fluid resuscitation, patient still hypoxic. So which of the following statement is true? The following ARDS net ventilation at 6 ml per kg. If his plateau airway pressure is 35 centimeter of water on PEEP of 14, his goal of tidal volume should be 480 ml. The first option. Second option is given hypotension, severe respiratory failure, PA catheter should be placed to optimize cardiac filling pressure and improve his chance of survival. Next is 6 ml per kg. Okay, given hypotension, severe respiratory failure, PA catheter should be placed to optimize cardiac filling pressure and improve chance of survival. Option C is strategy of doing recruitment maneuver followed by lowering PEEP until lung compliance is maximal will improve his chance of survival. Inhaled nitric oxide is likely to improve his PO2 FI2 ratio. Proning this early in ARDS has not been shown in favorable effect of survival. So what is your, tell me? Which is the correct option here?
Sir, D.
D is the correct option. Why not A?
Plateau pressure is more, sir. 35.
Huh?
Right, sir. It should be less than 30, sir, plateau pressure, I think.
Plateau
35.
pressure, yes. So one thing is that plateau pressure, our target goal is less than 30. So if with 6 ml per kg predictive body weight, ideal body weight, you are not able to maintain plateau pressure less than 30, you can reduce up to 4 ml per kg. And why not B?
So this pulmonary artery catheter is a static parameter of hemodynamic monitoring.
And nowadays is obsolete
obsolete,
also.
sir. Yes, sir.
And why not C?
Sir, high PEEP low tidal volume is the recruitment maneuver. It's written low PEEP, sir. So it cannot be the answer, sir.
Yeah. So, and why not E?
Proning will be the favorable effect of survival.
Very
We have
good.
written not.
Very good. So sometime you might be confused whether which is the correct answer, but you have to follow the each option and you have to check the tricky line like proning here early ARDS, it has been shown favorable outcome and only not has given. So if you miss this not, so when you are hurry, you might miss the not and you can give the answer E. So be careful about these things. Okay. So D is the correct answer. Now coming to the second question. Somebody can read this question. Okay. So 52-year-old woman with a history of DVD on warfarin and active smoker develops several days of epigastric pain and melena at present emergency department with hemoglobin of 5.5 tachycardia without hypotension. INR 3.9 platelet count is 2,15,000. Following transfusion of 2 unit PRBC and 2 unit FFP, she developed rapidly progressive acute hypoxic respiratory failure and increased work of breathing requiring intubation, chest X-ray, confirming the bilateral infiltrate. Which of the following statement is true of the most likely etiology for her respiratory decompensation? Tell me what is happening here. Why there is a respiratory new infiltrate? What is your diagnosis? Trolley is good. So the here the
Sir,
which of the following
ARDS,
statements true most etiology are respiratory decompensation? Yes, tell me what is the correct answer? Risk factor includes smoking and chronic
E,
alcohol
sir,
use.
E.
E.
Yes,
Okay. So risk factor includes smoking and chronic alcohol use. ट्राली में क्या smoking alcohol is a risk factor?
no, sir.
No. PRBC, FFP, platelet all confirm equal risk of this process?
No, sir.
Obviously
FF,
no. In
yes,
EDIC, if all thing is always negative, no. So which blood component is more risk factor for developing TALI, PRBC or FFP?
FFP, sir.
Yeah. And PRBC, usually if you give whole blood, it cause, but if you give leukodepleted PRBC, there is a chance of TALI is very minimum.
Yes, sir.
Okay, then incidence of this process has decreased dramatically in the last decade. True or false?
Yes, sir.
How many TALI you have seen in your ICU? Anyway, neutrophil are not thought to play an important role in this process. True or false?
It's a false, sir. Neutrophil has a role in the,
It is false. Neutrophil is main, WBC is the main. So among
yes,
the
sir.
WBC, neutrophil is the main culprit. Diagnosis of transfusion-related acute lung injury TALI can be made in patient with multiple risk factor of ARDS, aspiration, shock, pneumonia. The question is the E option is very tricky. Diagnosis of transfusion-related acute lung injury TALI can be made in patient with multiple risk factor. वहां पे TALI हम लोग जिसको risk factor नहीं है उसको बोलते हैं when there is a other risk factor is less and there is a bilateral infiltration after giving the blood product, then we think about trally. Agar if there is a aspiration, there is a shock, there is a pneumonia, why we will think about the trally?
Yes, sir. So the answer will be C, it seems, sir.
Yes. So incidence of this process has
It's a
decreased
decrease.
dramatically in last decade because nowadays we are not using whole blood, and also we are not using these things. We are using leukodepleted PRBC. And if you see the FFP uses also has been reduced because we are using cryo and others. So that's why the C is the correct answer. Now coming to this 53-year-old man, history of mild asthma, alcoholic cirrhosis complicated by ascites, control with diuretics, patient in the emergency department with shoulder pain after mechanical fall, musculoskeletal examination and plain film yield a diagnosis of acute acromicroclavicular joint injury. Vital obtained in the emergency department are notable with SpO2 91% on room air. He used albuterol MDI about once a week, denies dyspnea, and has no new pulmonary symptom. His lung examination is notable for subtle prolongation of expiratory phase without wheeze and chest X-ray is clear, which is true likely etiology for hypoxia. So patient having ascites, CLD, probably CLD patient with asthma patient now presented with a hypoxia after taking a your this injury, and he used this albuterol MDI. So which is the true for etiology of hypoxia? Spider nevi are infrequently seen. True or false?
So false. So spider nevi is seen for not infrequently. We can see it frequently in a like CLD
Yes.
patient.
Yeah. SpO2 tend to be dropped further in the supine position. यहाँ पे उल्टा होता है, ऑर्थोप्निक हाइपोक्सिया होता है, हेपाटोपल्मोनरी सिंड्रोम.
Okay.
हेपाटोपल्मोनरी सिंड्रोम में ऑर्थोप्निक हाइपोक्सिया होता है. Contrast echocardiography is the test of choice. Will come later on. Asthma is the major contributor. No.
Mild asthma, sir. It cannot
Mild
be the
asthma already written. It is never in indication for liver transplantation. It is an indication for liver
indication for
transplantation
liver
when there is a hepatopulmonary syndrome. Okay.
Yes.
So now coming to the contrast echocardiography is the test of choice. What exactly found in the contrast echocardiography? Actually, the contrast in echocardiography, contrast hindrance transthoracic echocardiography is a bubble study to visualize the contrast in the left side of the heart within 3 to 8 heartbeat or more rapidly is actually want to see the stunting effect, interthoracic stunting effect. So it is one of the tests to identify the hepatopulmonary syndrome. So,
how we do the contrast echocardiography, sir? Like
yes,
how
pardon?
we'll do the contrast echocardiography, sir? We have to give contrast and then we'll do the echocardiography. And what is the procedure? Like I don't understand. contrast echocardiography.
Contrast echocardiography एक बार देखना होगा boss.
ठीक है सर, थैंक यू.
I have no experience, so definitely I will find out and I will be put in the group. Contrast echocardiography. I'm writing down. So there are two area where you might get question in the CLD. One is the spontaneous bacterial peritonitis के ऊपर उसका criteria, diagnostic criteria and the treatment option and the antibiotic choice. And second is the hepatorenal syndrome. You have to know the full about hepatorenal syndrome and criteria for diagnosis and treatment. And the type 1 or type 2, which one is better, which one is bad. So
So
contrast
type 1 has a
hepatorenal syndrome.
the hepatorenal type 1 has a bad prognosis, sir.
Type 1 is a bad prognosis. So these are the question you might get in the hepatorenal syndrome. Now coming to the question number 5, 65-year-old man diagnosed idiopathic pulmonary fibrosis air ago, not on supplemental oxygen therapy, patient emergency department with weak and half worsening exercise tolerance, increased dry cough, myalgia, subjective fever. Over the last day, he has been unable to walk across the room without resting. Physical examination remarkable for SpO2 85% on 6-liter nasal cannula, tachypnea, increased walk of breathing, bibasilar crackles. The laboratory test result revealed WBC 10,000, slightly increased absolute neutrophil count, normal metabolic panel, and liver function test, troponin, normal liver function test also, troponin is 0.1 nanogram per ml, BNP is 120 picogram per ml. The rapid flu is negative. The PCR panel is pending. Chest X-ray worsening bilateral opacity results CT scan showing the figure. So what is your diagnosis on this CT? 1 year ago and now. So if you see 1 year ago CT, that there is a fibrosis also and UIP pattern. These are the area where you can see the UIP pattern, and this is the new area where patient suffering from ILD with acute exacerbation. Okay, the patient is the same patient, the patient is admitted in the ICU, placed on high flow nasal cannula, 40 liter per minute flow, overnight FiO2 range 0.7 to 0.9 to maintain SpO2 low 90, and he is unable to sleep because of dyspnea. On examination, he appeared to be tiring. Which of the following statement is true? Intubation and mechanical ventilation in this setting is associated with in-hospital mortality approaching 90%. The use of corticosteroid supported by moderate to high quality trial data. If metapneumovirus nucleic acid is detected in the respiratory secretion, then it is not appropriate diagnosis of acute exacerbation or AEIPF. Risk factor AEIPF include low BMI. Lung biopsy would be the most likely so organizing pneumonia.
नहीं हाँ पुलिस तो करना पड़ेगा
Hmm?
यस
So, what is your which statement is true? So the IPF, AE-IPF is one of the diagnostic criteria or say exclusion criteria when it is not is like more of a interstitial pneumonia. If acute origin interstitial pneumonia, sometimes we say the acute IPF, but here already it's make easy because he has a fibrosis, ILD, UIP pattern, and along with there is a infection. So the diagnosis is little make little easy, but use of now coming to the option E, lung biopsy would be most likely. So organizing pneumonia, no, lung biopsy is more of diagnosis of AIPF. So IPF may whether it is a acute or chronic, it can help on the lung biopsy, but and there is a treatment is same as the high dose steroid. Risk factor AIP include low BMI. No, there is a sometime it is idiopathic. And if metapneumovirus nucleic acid detected in the respiratory secretion that not appropriate diagnosis, no, it sometime precipitate with acute influenza or any viral illness can produce IPF. Use of corticosteroids supported by moderate to high quality trial data. No use of corticosteroid that has been given for a treatment, but you need to give her the pulse dose steroid, not the the corticosteroid. Pulse dose steroid has approved for treatment in IPF. And now coming to the intubation, mechanical ventilation, the setting in hospital, mortality approaching to 90% in AEIPF, the mortality is very high. So the on exclusion, the A is the correct answer. And remember that in AEIP, the typically the history will be less than 1 month duration. And diagnostic criteria in AEIP, CT scan chest will show the new groundless opacity and consolidation superimposed, and your consolidation more of an interstitial pattern. And another diagnostic criteria, your heart should be normal, the ejection fraction and the it should be preserved ejection fraction patient. These are the three main diagnostic criteria in AEIP. Now coming to the question number 5, 60-year-old with 60-year-old thin female smoker presented to the emergency department with several days of worsening dyspnea, productive cough, high fever. She remained hypotensive despite of fluid resuscitation and developed worsening hypoxemia. ARDS require intubation and mechanical ventilation. Central line is placed in the right internal jugular vein for vasopressor administration. She is admitted to the ICU and placed on low tidal volume ventilation protocol using high PEEP FiO2 grid study in the alveolar trial. 24-hour later admission, blood culture are positive for Streptococcus pneumonia, and her respiratory status has continued to deteriorate. Now 6 ml per kg ideal body weight, FiO2 0.8, and PEEP is 20 centimeter, and plateau pressure 29 centimeter is to O. SCBO to 75% while on moderate dose of norepinephrine. ABG pH is 7.32, carbon dioxide 40, oxygenation 65. Using volumetric capnography, you measure dead space is 75%. Several hours later, she desaturate and FiO2 raised to 1 with PEEP 24 because making the ventilator change, she has worsening hypotension and SpO2 remain low, less than 90. ScVO2 is remain at 55% and repeat ABG worsening that pH is 7.24, carbon dioxide increased to 48 and further hypoxia 59 with no change in minute ventilation from prior ABG. The another 10 minute SpO2 drop to low 80s. You are adding second vasopressor. Which of the following should you do next? So you are in a difficult ARDS patient where it is difficult to ventilate and stiff lung. Let's see. So what you will do, increase PEEP, start inhale nitric oxide, order urgent echocardiography, P protocol CT chest, transient disconnection of the patient from the ventilator. So patient profile, female smoker. So PEEP 24, do you want to increase PEEP? Already you are given PEEP 24.
No, sir.
So अब क्या करोगे? You are not able to maintain minute is on permissible hypercapnia category and difficult to ventilation.
He transiently disconnect the patient.
So उसका जो further hypotension हुआ, it is because of high PEEP, which increase interthoracic pressure and which not allowing to venous return. So first option, increase PEEP option is wrong. Now coming to start inhale nitric oxide. Inhale nitric oxide, sometime it increase the PO2 FiO2 ratio, but it is not available and not proven. It's not on the guideline till date. Order urgent echocardiography. So actually what is happening here?
Dynamic hyperinflation. Sir.
Little louder.
Dynamic hyperinflation.
Yes. So here actually what is happening, it's increase the dead space ventilation because it increase the worsening hypercarbia despite increased minute ventilation causing pH drop. And the history showing that female patient with smoker. So here the key point of this question, that patient is smoker. So there might be indication that patient might have a COPD underlying.
So start it.
So there is a chances of auto PEEP here. So that's why transient disconnection patient from the ventilator is the correct answer to reduce the auto PEEP effect. And why the supporting auto PEEP supporting point here, see that using volumetric here you have changes just the volume pressure control to volume control, and your worsening hypotension is there, and also your ABG is worsening, carbon dioxide has increased. So that can tell you that there is a auto PEEP is going on. So that's why transient disconnect from patient from the ventilator is the correct answer. So next question, which of the following is not true of mortality in ARDS? It said it has declined significantly over last 15 years. It is associated with very low PO2 FiO2. It is associated with high dead space. It is higher in patient under the age of 60. It is higher in patient with kidney and liver dysfunction, which is not true in the ARDS mortality. So ARDS mortality is decreased significantly in the last 15 years because of different protocol and reduces the ventilator related lung injury, and also the prone ventilation, ECMO has improved uh, the survival rate, and it is associated with very low PO2 FiO2. Yes, PO2 FiO2 severe ARDS, the mortality is high. It is associated with high dead space. Yes, the lungs is divided into three parts: the zone 1, zone 2, and zone 3. Here the dependent part is a solid part where it is not not participate in the gas exchange, and the middle zone is part where the part which you can improve the oxygenation by open up the alveolar, athletic alveolar by increasing PEEP. And there are zone 1 where the alveolar is normal. Here the baby lung concept come, and that's why the physiological dead space is high in ARDS and the main motto is to decrease the PQ mismatch by increasing the your zone 2 area, open up more and more alveoli, recruit more and more alveoli in atelectic zone. And obviously in high age group, older age group population with high comorbidity has higher the mortality rate, and it is higher patient, no sorry, here the higher age group with, if there is a high comorbidity, the mortality is high, but only the age is not a good predictor for the mortality in the ARDS. So the correct option is D. Now coming to the next question, 24-year-old man with a history of severe asthma with multiple intubation patient to the emergency department with several days of worsening dyspnea despite of frequent use albuterol names. The same morning visited friend who has a cat and his dyspnea rapidly worsened, chest x-ray to hyperinfiltration, a emergency physician gives solumedrol, continuous albuterol names, and initiate critical care consultation because of persistent accessory muscle use after an hour of care in the emergency department. Which of the following statement about severe asthma exacerbation is correct? Peak expiratory flow is predictive of arterial oxygen saturation. Intravenous magnesium is not recommended. The use of Helox is well supported in the literature. And following intubation, the respiratory rate should be set 14 to 20 breath per minute. And increasing intrinsic PEEP may help improve breath triggering during the resolution phase. So which is correct? So what is the main problem in the asthma patient ventilation? So because of bronchospasm, there is a chance of development of the intrinsic PEEP. So intrinsic PEEP will cause lot of problem. Like one is it increases the intrathoracic pressure, where decrease the venous return, and also it increased walk of breathing when patient in a spontaneous breathing mode. So that time, to reduce the effect of this intrinsic PEEP, you have to increase the extrinsic PEEP. And also in a controlled ventilation, if there is a auto PEEP is there, so you have to adjust in the ventilator by decreasing the respiratory rate first. If not improved, then you have to increase the I ratio by increasing flow rate or reduce the respiratory rate, or you have to decrease the tidal volume. Understand? So next question. 38-year-old, 155 centimeter, 50 kg, previously healthy female presented to the ICU with altered mental status, tachycardia, hypotension, and high fever. She is intubated for airway protection. Her laboratory test results reveal markedly elevated T3, T4 level with a decreased thyroid stimulating hormone level consistent with thyroid storm. Her arterial blood gas shows pH is 7.24, PO2 is 80, PaCO2 is 52, bicarbonate 22. Her ventilator setting are volume control, tidal volume is 350 ml, respiratory rate is 14, positive end expiratory pressure PEEP is 5, FiO2 50%. Which of the following is the next appropriate step for the management?
D.
D. D is increase the respiratory rate.
Yes.
So what is happening here? So you have to increase the minute ventilation to this patient. Here is the carbon dioxide retention is going on, that respiratory acidosis is there. So increase tidal volume to 500 ml. Why you will not increase the tidal volume? So tidal volume is 350 is 50 kg. So is ideal body weight is around 40, 45 is like that. So already 350. Okay, respiratory, you have to increase the minute ventilation, and the respiratory rate is 14. So respiratory rate is low here. Why low? Because patient is in thyroid storm, so his consumption of O2 is higher, the requirement is high, so you have to do a little hyperventilate to this patient. Now coming this question, which among the following represent the change in pulmonary respiratory parameter with aging? एजिंग के साथ साथ क्या चेंज होता है? Functional residual capacity and closing capacity. Functional residual capacity increase, closing capacity increase. Functional capacity increase, closing capacity not increase. Anybody can tell me what is closing capacity? FRC we all know. Functional residual capacity. Closing capacity is the point in which small airways start closing. So closing capacity, are we able to measure? So functional residual capacity, we know that this is the volume of the lung after end of passive expiration, and FRC slightly increase with the age and the height, and FRC decrease in supine position, obesity, and female sex. and closing capacity usually measured in ABC in 1 second, force vital capacity in 1 second. If it usually is a surrogate marker, and closing capacity small airway, how we will understand that it is increased with the age. Closing capacity increase with the age, and so option is A. Now coming to the another question, the 81-year-old female with history of atrial fibrillation on Coumadin. It is actually this quadrant. Hypertension and recent hip fracture from the fall of trochanteric fixation of the femoral head, who has been recovered in skilled nursing facility, is brought to the emergency department with complaint of altered mental status, high fever, productive cough, and patient in the emergency intubated because of lethargy, is transferred to ICU. On arrival to the ICU, patient vital are heart rate 110 beat per minute, BP 90 by 65 mmHg, SpO2 91%, on 60% FiO2, and on the ventilator. ABG is showing pH 7.38, PaO2 is 88 mmHg, PaCO2 39 mmHg, and bicarbonate is 22. Despite an increase the FiO2 on the ventilator, increased PEEP, and repositioning of the endotracheal tube, the patient oxygenation does not improve. The decision obtained X-ray is made and image obtained follow. So what is happening here?
Fat embolism.
Maybe some embolism. Let's see. This is the X-ray. So what appropriate intervention given these clinical findings?
Nasal decompression.
Hmm?
Okay. Nasal decompression, doctor.
So is it pneumonia?
No,
Pneumothorax?
looks like pneumothorax. Pneumothorax looks like.
Okay. Why pneumothorax? Deep sulcus sign is present?
Yes, on the right side.
Right side? No, the age is looking. Where is the deep
Sorry, no. Yeah, the angle is okay.
endotracheal tube is not clear picture, but endotracheal tube, this is the endotracheal tube here. Okay. So what may be cause of the hypoxia here? Picture is not good for pneumothorax because there is no deep sulcus, and here you can see this area is little, you can see the collapse, left lower lobe collapse, and
Bronchoscopy, I think, doctor, right?
here you are not finding that the cardiac.
Below.
Yes. So the option is perform bronchoscopy. If there is a collapse, you have to do a bronchoscopy. Okay. So 11 number question, 45-year-old previously healthy woman present to emergency department with 3 days of fever and progressive dyspnea and admitted to the intensive care unit ICU for influenza infection complicated by severe hypoxemia. She is intubated. Chest radiograph following intubation demonstrate appropriate place of endotracheal tube and bilateral patchy opacity, interstitial marking throughout all lung field without effusion. Her bedside echocardiogram revealed left ventricular ejection fraction 0.75 with otherwise normal finding. Her ventilator setting are volume control, tidal volume 500, respiratory rate 14, FiO2 1, positive end expiratory pressure P5, and initial arterial blood gas ABG is pH is 7.3, PaCO2 45, PaO2 80. Which of the following therapy has been best so improve survival patients such of this woman? বলো।
I think this is ARDS,
হুম
severe ARDS.
হুম
Think we can go with titration of PEEP.
Titration of PEEP. So
Lung
your
protective-
diagnosis is ARDS. So what ARDS net protocol said, diuretics to maintain negative fluid balance will help in ARDS.
No,
Lung
it will
protective
help, but not in the
So the option A, yeah, just
lung protective ventilation.
yeah.
B is right.
So এটা ধর এই ফোনটা কে ফোন করছে। So diuretics is not ventilation at 6 ml per kg ideal body weight. Yes, it may be. Initiation of inhaled pulmonary vasodilator for severe hypoxemia. Again, not proved, that is nitric oxide. Bronchoscopy to rule out additional infection. But here the problem is the hypoxemia. To improve hypoxemia and your so bronchoscopy is not appropriate management here. Titration of PEEP with recruitment maneuver optimizing lung compliance. Again, the why the E is not a correct answer, because recruitment maneuver is not recommended. All the guidelines shows that recruitment maneuver has not proved mortality. So that's why the ventilation with a tidal volume 6 ml ideal body weight, it can be in improve survival. Here the question is the improve survival. So that's why by exclusion B is the correct answer. B is the correct answer. So now coming to the next question, 68-year-old man, community acquired pneumonia, is intubated in the ICU with respiratory failure. Good. Following induction of anesthesia while paralyzed, is ventilator set on volume assist control, tidal volume 450, respiratory rate 14 beat per minute, FiO2 0.8 and PEEP is 5 centimeter. Inspiratory hold maneuver is performed. His peak inspiratory pressure is 25 centimeter, plateau pressure 15 centimeter. Which of the following true regarding patient respiratory mechanics? So what will be the normal gap for peak and plateau?
10 to 15, less than 15, doctor, the driving pressure.
Driving pressure, yes. So
Then the answer is C.
answer is
C.
why C?
Because that's the difference between the BIB and the plateau.
The patient lung compliance.
Uh,
Here it is
yeah,
said the lung compliance. How will you calculate the lung compliance?
I'm sorry, I thought was it driving pressure. Sorry, boss.
Yes, that is the thing. So you have to calculate the compliance over here. Okay. So, what is the deficiency in this question? Look at this. You have, if you calculate the lung compliance, so you have to have the pleural pressure value. Okay, without pleural pressure, you will not be able to the lung compliance. And the patient lung compliance is 45. Is the answer is given, but there is no pleural pressure. The patient chest wall compliance, the both you can't calculate. The patient respiratory system compliance is 45 is the correct answer. Why 45 is the correct answer? Because the your peak pressure, the peak inspiratory pressure is 25 and the plateau pressure is 15. So plateau minus P is your is a 10. It has to you have to calculate the static and the other make compliance. Then the answer given is the exclusion answer. The patient respiratory system compliance is 45 ml per centimeter H2O. But the explanation of this question given that because of there is no pleural pressure, you can't calculate the lung compliance and the chest wall compliance. So next question come. Today I will finish up to 15 question and total we have a 30 questions. So I have to take another classes. Otherwise it will go 11. So I will finish by 15. Then again I will take another class for rest of the question. So 54-year-old man with a ischemic cardiomyopathy is admitted to the ICU for respiratory failure due to decompensated heart failure and cardiogenic pulmonary edema. On the day of admission, he required intubation, mechanical ventilation, aggressive diuresis is initiated. On day 3 of his ICU stay, his ventilator is set on pressure support with driving pressure 5 centimeter is to PEEP 10, FiO2 0.3. He is fully awake and breathing comfortably. He is placed to spontaneous breathing trial with pressure support setting of driving pressure 5, PEEP 0, FiO2 0.3. Within minute, he experienced oxygen desaturation, tachycardia, and respiratory distress. Which among the following most likely cause for failure of his spontaneous breathing trial? Bolo.
The heart failure. So decrease preload and increase afterload.
So your answer is heart failure.
Yes.
Okay. Anybody differ? So why this heart failure happen here?
Due to the decompensation.
Yes. So atelectoma from collapse alveoli with tidal breathing is not the cause. Mucus plugging for lower airway pressure, not the cause. And increase preload, decrease afterload, or decrease preload, increase afterload. Here, what
E.
happening? E, the increase preload and increase afterload. So because you are giving a positive pressure ventilation trial and you make PIP 0, so it increase your preload as well as increase the afterload and the worsening of the heart failure again. Now coming, sorry, पीछे जा रहा है क्या? हाँ, this one. 48-year-old man with no prior medical history is admitted community acquired pneumonia, severe acute respiratory distress syndrome. On day one, his illness, he is admitted to your ICU on the volume control, assist control ventilation, tidal volume 4 ml per kg, ideal body weight, respiratory rate 32 breath per minute, P14, and FiO2 100%. On those setting, he found to be hypoxic. AVG that demonstrate pH is low, PaCO2 is 65 and PO2 55. Which of the following intervention most likely to improve his survival? करना क्या है?
Brom position, that's the only one to improve survival from these answers.
Yes. So why not ECMO?
First we have to prone, then ECMO is a consideration.
Or actually,
ECMO is the last resort, only bridging therapy.
yeah. So always before doing before you are think about the ECMO, you have to think all the conventional method first and then ECMO, because ECMO there are two disadvantages. One is it is costly, and second, the survival rate in the ECMO is only 30%. And also because it is extracorporeal, there is associated with a lot of complication. Now, last question for today's session. 22-year-old woman with a history of asthma, previously intubated twice, present to the emergency department with worsening dyspnea over past week and is found to have influenza. Her chest radiograph demonstrated bilateral patchy opacity and she is intubated for hypoxic respiratory failure, received empiric antibiotic, bronchodilator and steroid. The ventilator setting are pressure control, assist control with inspiratory pressure 25 centimeter H2O, PF is 5 and respiratory rate 24 breath per minute. On arrival, ICU, she remained paralyzed after rapid sequence intubation. And then the above settings is getting tidal volume 200 ml. Which of the following statement most accurate regarding her ventilator setting and physiology? While she is paralyzed, her compliance can reliably be calculated from her inspiratory pressure and delivered volume. While she is paralyzed, you need to measure the pleural pressure to reliably calculate her pulmonary resistance. When her paralytic wear off, you would need to measure pleural pressure to reliably calculate pulmonary compliance. Her pulmonary resistance is best assessed by looking in the difference between her peak inspiratory pressure and pressure during end inspiratory pause.
The last answer, the
D.
yes.
The answer is C. Why? It has been her it has been said that the peak inspiratory pressure will be the same as pressure that ventilator set during inspiratory pause, and the resistance we calculated from the number. So that's why pulmonary resistance is best assessed looking at the difference between her peak inspiratory pressure and pressure during end inspiratory pause. So pulmonary resistance, we calculate peak pressure and the plateau pressure. So D is the peak and plateau difference.
मेरे को मसूर की दाल मेरे को क्या पता, आपके बता देती, मेरे को नहीं मालूम था ये नहीं खाता मूंग की दाल, तो मसूर की बन जाती।
So why C is correct answer? Because when you are giving the paralyzing agent, you have to measure the transpulmonary pressure by esophageal balloon. So once you can measure the transpulmonary pressure, you can calculate the pulmonary compliance. This is the explanation. And why D is not correct? Because the resistance cannot be calculated by this peak and plateau difference. But there is a doubtful. D may be the correct answer because we calculate the pulmonary, assess the pulmonary resistance, but air, oh sorry, it is not airway. We calculate the peak and plateau difference is the airway resistance, not the pulmonary resistance. So that's why D is not correct. Understand?